Hi, everybody. This is Susan Clinton. You are one of your co-hosts for Tough to Treat. This is episode number 204. And in this episode, we're going to revisit a couple of themes that we have talked about before on previous podcasts. Um, People come to us with a specific diagnosis, but when we open it up and take a look at everything that's going on, we find other reasons that this diagnosis may be existing, or the symptomology that gives it that diagnosis may be existing. So I hope you enjoy this. As always, if you have any questions, please leave us a message at toughtotreatpt@gmail.com or www.toughtotreat.com, and enjoy the podcast. Hi, everybody. Susan Clinton here, one of your hosts from Tough to Treat, and I'm here with Erica. Hi, Erica. How are you today?
I'm good, Susan. How are you?
I am doing well. This is podcast number 204.
Or,
And I know we're moving along here in 2024, and it's podcast 204. So
we
hopefully we will keep getting good reviews, and please let us know how you like it. I know we're on YouTube now too, so leave us some notes in the
get the comments.
message us in the comments exactly down below, and like and subscribe to our channel. Help others find us.
Yes, and no, I was going to say sometimes we don't get notifications about the comments on YouTube for some reason. So we'll try and check them, have our assistant check them as well. We would love to engage with the audience. So if you have any questions, feel free to either email, as Susan said in the intro, or comment. And we're going to do more video on YouTube now. So tell us if you like it, and if it helps you in your practice, or if you're not a physical therapist, if it helps you in whatever reason you are listening to us for. You
Okay.
ready,
Yes,
Susan?
I'm ready.
Okay.
Okay. So this client is a lady in her mid-50s, came to me complaining of and wanting treatment for overactive bladder with leakage. In the pelvic health world, we call it urinary urge incontinence. Um, so I'll just kind of buzz through the history here. She has a long history of mild urinary incontinence that mainly was an issue with running, jumping, and has worsened over time, and now has this urgency component to it, which is generally the way that this progresses if it's not treated early on. She's an active person. She likes walking, she likes biking, and she does some strength training. And she just decided to come to physical therapy to have this overactive bladder issue managed. She's done some reading on it. She knew that she needed to work with somebody, and her expectations were that we were going to help her with those symptoms. Um, so definitely, we're going to look at those symptoms and talk about them. But as always, I'm going to go a little bit deeper. So I asked her about any injury history, any past medical history, any other things that she's on. Always looking for if they're on some sort of blood pressure medication, they have fluid management problems in their legs, anything else that would tell me more about the story medically. She's all good there. She did say that her sleep is disrupted by getting up to go to the bathroom a couple of times a night now, which she doesn't like. But she's pretty active, and she has a pretty busy life. She's working part-time. She's not sitting all day. She's up and about and moving around. So, we don't really have those issues of somebody who's sitting with fluid pooling in their legs all day and then having to deal with it with diaphoresing at nighttime. So, she was pretty good about managing her liquids. She was doing a lot of what we call bladder irritants, a lot of acidic foods, lots of coffee, things that can make that a lot worse. Um, so we had to talk about that, and some of those health things, health behavior things that can begin to change this. Because of the incontinence, she did have a tendency to restrict when she was going to be out and about liquids, and then overdo in the later part of the day. So we had to
Um,
talk about that, managing those things out as well. So, um,
any kids, Susan? Any kids?
um, 2 kids.
Oh, two kids. Okay.
Yeah, all in college. So
Okay.
she had her kids young. They're
Oh, yeah.
off in college. She has some time on her hands now to take care of some things. And yeah, so it's good. So anyway, I did ask her about old injuries, any kinds of other things that were going on that she had. It took a little while for her to kind of dig back. She started off talking about how her hip hurts on her left side. She doesn't think it has anything to do with her bladder, of course. And
Mhm.
but she did tell me that it used to hurt mostly on the inside, like in the groin area. And then she said, but now it hurts on the outside as well. And when it hurts is when she stands for long times on concrete floors or, like standing and cooking, things like that, where she's just standing a lot. And if she does any exercises at the gym, such as deep squats, deep leg presses, and the abductor adductor machine in that sitting position, which I hate.
Yeah.
So kind of digging in. Then she kind of got on the story about her hip and what had happened. And she fell about 20 years ago, ended up what they kind of finally diagnosed. She had growing pain off and on, off and on, off and on, off and on, off and on during her pregnancies that she attributed to her left to this hip injury versus, maybe just changes in pregnancy, especially cortisol. So she long history of this, and she finally said that all along they kept telling her she had a labral tear. So she finally had surgery, and
Mm,
it didn't help.
no,
Um,
surprising.
she said it. She just said it really didn't change anything. It didn't make anything worse, but it didn't help. She's also developed some mild left lower back problems, just issues. And she says it's mostly when the left outside of her hip hurts. That's when her back is bothering her a little bit more. If she stands, for a long period of time, it bothers her. So just, she just kind of just brushed it aside as this is just something normal. I'm
Oh,
getting
I
a
see.
little bit older. Everybody's telling me this is the case, which I wanted to kind of like, stop, kind of reframe that thinking a little bit that, I think that if we look at things a little bit differently, we might be able to help you resolve some of your issues. And this very well could be feeding into your bladder issues because
Mhm.
they share the same fascial attachments, they share the same neurology. There's a lot of things, muscles can be overworking and underworking, which can, give us problems through that area.
Mhm.
One of the things she finally did say after some good questioning was, she revealed a pretty good history of constipation.
Mm,
Never seen a bladder issue that doesn't have a GI driver behind it. So
interesting.
we've got somebody here with a visceral driver probably, as well as maybe some musculoskeletal drivers that are just adding up to the symptomology of this urgency frequency, and now unfortunately some leaking with it. So rushing to the bathroom but not making it, feeling like she needs to wear some pads. She hasn't done any running or jumping because her hip hurt with it, and walking feels good. She likes walking. She likes riding her bike. It feels fine, so, those
Oh,
are
interesting. She can
non-issue.
ride her bike, but she can't do a deep squat or a leg press.
Right.
Okay.
Yeah, interesting, right?
Yeah.
So,
Yeah.
we'll get
Yeah.
to that in just a second. I'm glad you
Okay.
picked that up.
Mhm.
So, um, anyway, so you got the current history.
Yeah.
So,
What?
I told her, of course, I said, "Let's just take a look at everything, but before we do that, let's take a look at some things that are meaningful first for you." And so show me where you're hurting on your back, show me where your hip is hurting. She basically around the greater trochanter area, she kind of pointed into the, inner groin area. I said, can you move your leg in and out, like rolling, doing hip internal and external rotation?
Yeah.
And of course, yes, it felt worse with internal rotation. It felt somewhat better with external rotation.
Mm,
Um, and I just said, just show me a deep squat. Just show me what it looks like. And so she brought her feet apart slightly, and then she went down in a deep squat, but I'm telling you, she was all the way over on the right side, and that left knee was coming in,
Yeah.
it was, like, dropping in medially just a little bit. The right one was too,
Mhm.
but the left one really was. And
So,
she would
so
get just past 90, and she would go, "That's when it starts to come on."
okay, so was her center of when you noticed her starting going to the right, was it immediate or was it when she got into the deeper squat
She was on the right to begin with, and
and
then
oh, and standing and she
and it
went
got
further?
and it
Got it.
got worse, yeah.
Got
So
it.
as she came back up, I just had her do a couple of other things that were meaningful to her, that, I said, "You don't like the leg press. Can you just lay on your back and show me, like, the position of the leg press?" I just took, kind of a board and put it on her feet, and I said, "Just, like, let's go down with it." And she said, "It doesn't hurt so much on the way down. It would hurt to engage and push it out."
Uh,
And it's very interesting, because I'm thinking to myself, okay, when she's standing and squatting, she can get away a little bit. But when she's on the leg press machine, she has to engage that equally. So if she's twisting or turning to try to do something with her hip motor control plan, it kind of makes me wonder. So, but the leg press hurts way more than just the standing squat, which would make sense to me.
right, because she can't, her thorax is fixed on the on the machine. She can't really
Yeah.
cheat that
She's
way.
on her back with with her
Yeah.
feet up
Yeah.
against the machine. She starts with
Yeah.
it, like, almost in, partial extension, and, like, lets it come all the way back and then pushes out.
Yeah. Yeah.
So it was just interesting to look at that, and I talked to her and I said, I'm just kind of wondering, as we do some of these things, is this increasing, like, any of your other symptoms? And it was interesting because she did say, she goes, when I'm doing these types of things at the gym, I always feel like I have to go to the bathroom.
Mm,
It's like, okay, that kind of connects some dots for us, doesn't it? And
that's
she said, I just never put the two together. I just thought it's because I'm exercising and now I have to go to the bathroom, or I drank too much water before I went to the gym, or, that kind of thing. She never put the idea that these particular movement patterns actually increased her urgency frequency symptoms.
mm,
So, we talked a little bit about the muscles and how they all connect in and where they connect in on the pelvis, and, how they share the fascial support. So if one's over pulling, it can pull against the urethra and give you that kind of symptom, especially since you're staying over on one side all the time. When she does stand on the left, she tends to internally rotate her hip, to stand on that left side. When she stands on the right side, she's a little bit more even, but she's been standing there for a long time.
right.
Um, so, it was good to get that little bit of buy-in before we even went to the pelvic floor exam and the other pieces. So I got a little bit of the behavioral health, issues in there, and we got a little bit of the how these movements really affect it. So here's the thing. One of the things that we know from the literature is that if we can increase lateral hip strength, abductor, external rotator strength, that can actually help improve symptoms of OAB. It certainly helps with urinary incontinence too. So we know
Mhm.
this, but here's the thing, we've got somebody in her 50s, where things are starting to worsen now. Although she hasn't been doing anything different since she had the hip stuff, but things are just starting to worsen a little bit. She's not sleeping as well at night. There's, thinking kind of along the lines that, I wonder if what's happening now, the development of the pain on the outside, when I could poke and palpate in there, you could get right on that abductor tendon, and it was quite tender, to touch. So I'm starting to think, I wonder if there's a bit of a tendinosis going on here.
So is it
Um,
OAB? I'm assuming that's overactive bladder, just for the
exactly.
listener. Okay,
Yes, yes, yes.
got
So,
it.
overactive bladder.
Got it.
So I'm just wondering how much of the, is there a tendinosis setting up in here? Because he doesn't like it when she gets into extreme positions, and she certainly doesn't like it when she's standing for long periods of time, especially on unforgiving floors.
And when she loads that left side, even if she does load that left side, which doesn't seem like it gets much opportunity to get
Right.
load, when she has to,
Mhm.
it's not prepared.
Yeah, exactly. And so we just did a couple of things in open chain because I wanted to see how it was. And she didn't like laying on her side and doing a side leg lift. She didn't like, if we put something around her ankle stepping out, she said, "That bothers me at the gym," using the cable cords, and trying to do step outs with the D-ring and the Velcro around the ankle,
Mm,
so she can do it going backwards, she just doesn't like going sideways with it.
maybe duction.
Yeah. On the bike, I think the reason that it feels pretty good is because she just stays in one position there.
Right brain, yeah.
But I asked her to take a picture, to do a video of her on her bike. So she did, and it was very interesting because you were asking about she can go into a deep squat, but yet the bike doesn't bother her. Here's the thing, when she's on her bike, she couldn't really describe it to me, but her handlebars are up, so she's sitting up taller, and
Mhm.
she really is getting a lot of bend over at her thorax, and her back and her pelvis and everything are not going into a deep squat. Does that make sense? She's up higher,
Yes.
so all of the things that are happening are she's hinging mid-thorax
Right,
rather
so
than hinging at her hips, and
right.
she said that she adjusted her bike and did all of this because that's the only way she can ride without pain. And I was
Okay.
like, "Bravo, go for it."
Yeah,
Like,
yeah, I mean, it
"Great."
didn't hit the angle that the load and the angle was not as much as the deep squat,
Right.
plus she was off her feet, but still,
Mhm. Yeah, it's a closed chain exercise, but it's not a standing still
right.
onto the floor exercise, kind of unforgiving floors.
Yeah.
So here's the thing. So how do we the question I had for myself was, how do we look at this and work with this, given there's maybe a brewing tendinosis, but still help her regain her center of mass and help her regain capacity on that side and reduce her symptomology?
Was she looking for you to do an internal pelvic exam? Is
Mhm.
that what it was?
Yeah.
Okay,
Yeah, and I'll get to that in just a minute, but
okay,
that's
got it.
what was
Yeah,
going on in my head. It's like no
got
matter what I find internally,
right,
the
right.
musculoskeletal package, the constipation has to get better, so does some of the behavioral health. So
Yeah, yeah,
it's an integrative package here. I
yeah,
absolutely did do an internal exam. That was an expectation,
yeah.
and we definitely found over recruiting muscles, not painful on the left side, but definitely when I was able to palpate into the obturator internus on the left side, she definitely could feel the symptomology, the urgency frequency, like, oh, that makes me feel like I need to go to the bathroom.
Mhm.
And then the palpation of the left lower quadrant, you could definitely feel stool, being held in the descending colon. So constipation is an
On the
issue.
abdominal palpation you're
Yeah,
talking.
abdominal palpation.
Yeah,
Yep, right into the left lower quarter,
yep.
along the line of the iliacus. So,
Mhm.
how much of that was an issue for the growing pain? Hard to say, right? But we have a lot of things that are occurring here, and just kind of like, so I wanted to see what her trunk did with rotation. So I just had her sit
Yeah.
because again, all of those nerves that go to the ilioinguinal, iliohypogastric, and those all come from, the thorax and the lumbar, that thoracolumbar junction. We did some rotation. Nothing really chimed in hard or caused a problem.
In
Um,
sitting rotation or
and
standing?
sitting, and
Sitting.
sitting. Yeah, I wanted to keep pelvis still and just rotate the upper trunk. We even
Mhm.
put the arms up and did it. Still no problem. But when I got her in standing and I had her stand in stride, right foot first, left foot back, and and just stand, kind of balance and stride. And I just had her bring her arms up. And as soon as we started to rotate towards the left side, her OAB, I can feel she was now aware. She was like tracking.
So she was in
I
a right
feel,
leg in front, left leg back, hands
uh-huh.
like this, and she was turning to
Hands
the
up like
left.
this and turning to the left,
Okay,
because
got
that's
it.
how you increase the neural strain and on the abdominal wall, the neural
Got it.
tension in the abdominal wall,
Got it.
and the leg back for genitofemoral.
Yeah, yeah, yeah. Left
So
leg back.
it took
Perfect.
a lot
Okay.
to wind her up.
Yeah, yeah. Well, that's good though.
Right? So,
Yeah.
but there, okay, so there is a little, so we have to think, okay, is that true neural tension or is it winding up of the fascial system? I don't care. It brings it on. So that tells me that, all right, so we can back off of that and do some work in there. Let's get some
Mhm.
rotation going in here.
Mhm.
let's see what happens. So this is by like the second or third visit, because obviously I could do all of this in the first visit. So first
Yep.
visit, we did some behavioral stuff. We did a pelvic floor exam, and I watched her do those meaningful movements and gave her some things to work on, right?
Mhm.
So by the second, third visit, we're getting more into it. She's watching her, she's, drinking her water slowly. She's replaced a couple of cups of coffee with some herbal teas. She's starting to like work on her constipation and be serious about it and not blow it off. And, chewing some good vegetables and adding a little soluble fiber into her diet is helping. So we're doing all the pelvic health stuff in that realm. But, we're continuing to work here on this musculoskeletal. So it's finally time to take a look at what happens in the one-legged series
Yep.
here. So I already know she's shifted off to the right in her center of mass. So I wasn't surprised that she could stand on her right leg without a problem, and I certainly wasn't surprised when she stood on her left leg that there was a twist into internal rotation at the hip, and then actually kind of a shift back over with her right shoulder up to try to balance her on that, and she couldn't hold it.
Yeah.
And she said, if I had to stand here for a while, it would hurt.
Yeah. And that's what you saw in the squat too, with the left knee going
Yeah,
into some
right,
internal
right. A little bit of that tendency towards left internal rotation, and following the literature, hip angles makes a big difference in the pull on the periurethral fascia and the support of this pelvic and pelvic organ system.
Yeah.
So yeah, but here's what really was interesting. When I had her stand on her left leg to lunge on her right, she really did this weird right shift. Like, so I got her to stand, in between, like, let's get you back over between both legs. And
Yeah.
I want you to just lunge forward with the right leg.
Okay.
But in order for her to do that, she had to actually you know, A-B duck that left hip to get the right leg off the ground to put it over, because she's not used to standing on that left side.
Oh, yes, of course.
Right?
She doesn't have that motor program in her brain to do that.
Exactly. And then when I had her stand on her right and go down on her left, she could stand on the right, she could put the left foot down, and then as soon as she started to put weight on it, the knee went in.
Yeah, 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 yeah.
Yeah. So pretty predictable stuff, but important stuff, because here's somebody who for exercise does bike riding, so I'm showing this for those of you who are
Symmetrical.
listening. I've got
Yeah.
my hands going like a bike,
Mhm.
and or walking, but she's not doing, she's not, the deep squats don't feel good. She's not a lunger. She said, I don't do lunges in the gym. I've tried to do the step outs. I used to do them all the time. But they bother me now. But I really like doing them because I feel like I should do them.
Mhm.
The lunges she realized were a mess. So it's like, it's not a big deal. We can clean this up and get them going where it doesn't hurt. We just have to back up a little bit and do some different things. And let's start with some standing on one leg, because that's an exercise you can do just about anywhere.
Yeah.
And so we start, put the hands on the wall again to
Yeah.
just kind of give her a sense of
Center.
midline and let her start working on it, and, just really helping her control her pelvis, because that was the thing that she could think about it. She can't think about, well, you're leaning on your hip funny. I mean, it was just like pelvis stays here, the headlights on the highway moving down, this is
Mhm.
where we're gonna work, and
Yeah.
got her to where she could kind of start to feel that, yeah, that now I can kind of start doing, like, lifting my foot up on the right without getting all wonky,
Yeah. Yeah.
and so we could progress into step up, step downs, and then we progress into side step up and side steps downs. But
Mhm.
we kept the step low in the beginning because, again, you've got this brewing tendinosis on the side that I don't wanna turn into a maelstrom, of
Right.
problems.
Yeah.
So I thought, okay, she really likes the step out exercise, but it hurts.
Yeah.
She said, well, what if we put the TheraBand around your right leg and and then tied it around your left leg, and you did a step out with it around your thighs.
Mhm.
That
Yeah.
felt a lot better. The
Yeah.
lever arm, so shorten the lever arm. When
Yeah.
you're thinking about how to increase capacity, but everything they do hurts, is like, can we shorten the lever arm?
Yeah.
So that the work that they can do can actually be different, because the physics, the longer the lever arm is, the more, work the tendon has to do up above, and that was bothering her.
But also with the biking, she's 4 points of contact pretty much, right?
Yeah.
You
Yeah.
do the against when your hands against the wall, it's 4 points of contact. So the wall gives her a reference for center, her brain a reference for center, and
Mhm.
if that's I always have patients imagine a line drawn in between your hands, or because a lot of them don't have a mirror, but those hands on the wall really give the patient a reference for center. And even if
Mhm.
you spend a week doing that, it's a week well spent, I think.
Mhm.
Right?
Yep. Yep. Just kind of, and then again, monitoring what her bladder symptoms were too.
Yeah.
Because she was kind of getting a little bit aware, like, that's interesting that if I do this, that begins to happen.
Yeah.
And, I said, some of it is just, it's, you've got a little bit of a visceral driver here, that's kind of, has a bit of a hair trigger. So as soon as your bladder wall starts to stretch too much, it's going to fire off because it's used to being little because you've kind of given into it for a long time. So we have to pay attention and help that stretch a little bit more. But let's give it a better container to work in too.
Yeah. Yeah.
And let's also help your gym routine because she liked her gym routine and she was getting a little frustrated because things weren't, I mean, she liked the feeling of going to the gym and doing strength training, so I wanted to keep her with it. So we eventually increased from the TheraBand and the step outs and monster walks to, her using the cable cord, but doing it up high
Yeah.
around her thigh instead of around her foot. And,
Mm.
and I told her, as you get better and as this improves and as you feel good, you'll be able to go lower and lower on your leg with it.
Yeah.
But here's the thing, we also did it on the right side, and she struggled with that because now she knew how to change her center of mass back over to the left, and she could no longer do it well around her ankle on the right side because of the work she had to do staying, just having nice, good control on
Mm.
that left side, staying on that left side, and not letting herself just kind of wonk off to like step out.
Right.
And
Right.
so she had to bring it up onto the right thigh too.
Yeah. Yeah. Yeah.
And, so we're getting, more of the capacity building going on across the pelvis here.
Yeah.
And, her step up and step downs got better. What we did for the deep squat was target practice at first. So me and the, like the wall, me and the doorknob squat, it was like, we went, show me how far you can go before it starts to hurt.
Mm.
And so she played around with it, keeping the door in midline, and she was able to identify, like right about here, I can feel it starts to bother me. So we built up a surface underneath her and I said, this is as far as you go. Work on this.
Yeah.
And
Yeah.
then, and as that gets better, we moved it down and moved it down to where she could actually like almost go down to like the size of a big medicine ball.
Yeah.
And so then she did it without the door. So then we were able to kind of like increase that so that, because again, here's somebody who said, I want to work out at the gym. I want to be able to like do a bar. I want to hold dumbbells. I want to, have this. And so, she was able to start doing some work with the, the bar and the dumbbells in front and behind her, very lightweight, but she used the medicine ball as her target.
Yeah.
So she
Yeah.
knew that, okay, I'm good if I go here. And does that still feel good? And
Yeah.
where am I on my body?
Yeah.
So she could, if you use a weight rack, it's a little bit easier because you can't go too far, it's not going to fit back up onto the thing
Yeah.
if you're off to the side. And people can even like drop I've seen people at the gym. I had her just take one of her big long bands
Yeah.
and tie it up where the above the where the weight rack was and her barbell,
Mm.
and I just said, "Just watch that. Put it right in the middle, and just, make sure you're staying, like, right in the middle with it." And that was a nice visual cue for her, but people can figure out visual cues to stay midline.
Yeah. Also, sometimes I have patients go up, if they're having a really hard time with center of mass, I just have them go away from the wall, but each butt cheek is on the wall. And so I have them do like a little side to side. And I'm basically cueing, if you feel one butt cheek is coming off the wall, you're inducing a rotation translation.
Mhm.
That's not what I'm looking for right now, right? And so I
Exactly.
had somebody
Mhm.
recently, just that I thought of it, and I think he could go to his right really well. He had a foot issue. Then the left, he was coming off the wall. He could not maintain center. So that's another one away for if people are, if they're just not getting the, facing the wall or anything like that. It's a good visual. And it's also, you get the buy-in. You're like, oh wow, I actually should be able to do that fairly centered, right? And I also thought of something with you were talking about the cable, with her lunge. you could also have, just for the listeners, if you throw like, the cable columns of the tricep, the
Mhm.
cable pulls, you could have her pull that, and that could maybe get her a sense of center, so similar to the bike, and have her do like the lunging out. This is like advancing the program, but
Yeah.
I'm just thinking of that as you're talking.
Yeah, 100%, and that's what I was gonna get into for the
Oh,
lunges.
there you go.
I actually kind of did it backwards. Instead of her lunging forward, I had her do a step back lunge instead.
Yep.
She had better control, and she
Yeah.
could do it, and so we started by just kinda holding on, side by side, like a couple of chairs, and then we progressed to being able to hold on to one of those big bands so that it would assist her coming up or going down, like, she could, like I said, "Just pull it down in front of you." So there you go, Erica, with the 2 hands on it,
Yeah.
to kind of, like, give her the 4 points, and we started working on not just the step back lunges, but the step forward lunges and
Yeah.
some split squats, easy, because she needed to have the control on both sides with one leg out in front and one leg behind.
Yeah.
And then, certainly you could progress, as you talked about, to, doing both arms pulling straight down and
Dynamic. Yeah.
going into the lunge and coming back
Yeah.
and bringing those forward and back. So, um, what ended up happening with her is her symptoms got much better. I also, for the pelvic health listeners out there, I also started her immediately in the beginning once we started getting the behavioral changes going, as far as like the water, the coffee, the acidic foods, making some of those changes. I also got her the just a basic TENS unit to do the posterior tibial nerve stimulation, which you do around the ankle. Um,
Or or
for her overactive bladder symptoms, it works beautifully. 3 times a week at a 30-minute session. The wavelength is or the, it's a 10 with a 200 wavelength and, the intensity is lower than the motor response. Um,
they've been doing that
there's
for a while now, right, Susan, for
Yeah,
overactive
we have,
bladder?
and why more people aren't using TENS for this, I don't understand. It's
Mm,
such an easy modality. You can get a TENS unit right off of Amazon,
yeah,
um, for $30. It's like it's so easy. Anyway, that also helped immediately with her symptoms, particularly at night. So that she was sleeping much better. Within a month or so, she was sleeping much better. Many nights not getting up until only
mm,
one, and maybe after about 6 or 6.5 hours of sleep.
yeah,
But it helped her with her bladder so that she could actually train it to be bigger. She could, she had longer times between voiding so that and it wasn't as uncomfortable. And so
mhm,
that really, really helped. So that was the other little piece I threw in there for her
yeah, yeah,
while we worked on her musculoskeletal, motor pattern
yeah,
so that she could do the things that were really meaningful and relevant. She thought that she was just gonna come and do pelvic floor work, which was great, teaching her to, breathe and get her pelvic floor going and make it more have better range of motion. But that was gonna be single and isolated until we put it back in the container. So with her, I was able to help her get going pretty quickly with the movement pattern stuff while she's working on all the other pieces like an integrative program versus, first we do treat this and then you go to the gym and do this, and it
yeah.
actually works so much better if we put it all together.
Yeah, I'm very curious. So I was talking to somebody recently about when you have patients who, particularly the pelvic health, when you have somebody who's chronically loading one side of the body, let's say in her case, the right side,
Mhm,
this particular physio said to me, she's like, I often 90% of the time I find on the opposite pelvic floor, the left side, an overactive pelvic floor. So it's the
mhm.
opposite their center of mass. I'd be curious to see if that's what you found or if the listeners have found that as well. It's usually the opposite side of the like so right center of mass, her left side of her pelvic floor is overactive. And 90% of this particular physio's patients, she sees that. And I'm just
Mhm.
curious as to what your thoughts are of other
Well,
physical.
it makes sense because we see that with the adductor, right?
Right. Exactly.
Mhm.
You don't use
And so
it,
the
you become
adductor,
stiff.
pelvic floor,
Yeah.
obturator internus muscle, they're just set up to work because if they don't, that person's just never gonna have their foot on the ground.
No.
So it's those muscles pull to try to, bring them back or to try to balance that pull that's going the other way.
Yeah.
I don't wouldn't say I always found that, but I would say that that makes it's definitely a pattern to look at.
Yeah,
Um,
yeah.
if you're not sure what's going on, look at the adductor and see what it's doing. It's generally tighter and over recruited on that opposite side as well.
Yeah, because you're not using that virtual part of your body, that your left side of your body, so it becomes stiff. So, for the non-pelvic health, that side of the body will just become stiff, not used. Um,
Mhm.
you know, it,
And it's
it,
how we line ourselves up under gravity. So everybody can do this if you want to out there in the listening world is stand normal and then take, and we're going to exaggerate it, but I want you to feel it. Take a big step to the side, shift your weight, leave your other foot on the ground, and feel the tension in your adductors and if you can in your pelvic floor.
mm, yeah, yeah,
Putting ourselves under gravity different, and so different muscles are going to turn on and
yeah,
try to work differently. It's no different than a forward sway or a backward sway.
no, yeah,
Forward sway, you're going to feel your gastroc, soleus muscle just kind of like, whoa, got to hold on here. You
yeah,
backward sway, you're going to feel it in your quads.
yeah,
So same thing. So like, you can kind of picture that. It's, usually when people have adductor strains, it's when they're going from a point to where they're really abducted into a crossover adduction type of thing. So
mm,
there's a lot of tension in that, and it's that cross kind of work. Though there's going to be more tension on that side as you shift away from it if you keep the foot down on the ground.
yeah, yeah. And I think ultimately, you know, some people will say, well, if they're in a certain sport that's very side specific, she wasn't, but you need,
Mhm.
training that center of mass, or however you do it, directly or indirectly. You need to be able to give your patient choices for movement. She needs to go to her left side in life, getting out of the vehicle, right? Getting out of the
Yeah.
car goes to her left
Mhm.
side, right? So it's worth it to do movement patterning like that and clinically reason why you're doing it. And if it's not, if figure out why she's loaded, like we talked about at our CSM, what set them up, what kept them there, right? Our combined sections.
Mhm.
So this is a perfect example because she had bladder symptoms too, right? And
Mhm.
just treating her bladder, it would
Wasn't
probably,
going to yeah, wasn't gonna tell the whole story, or it wasn't going to be as an integrative approach.
yeah,
I feel very strongly that these things need to happen together versus like, well, first we'll do this, and then we'll do this, and then we'll do this, and you can layer things,
yeah,
but if they don't tie the whole thing together, sometimes, the whole system isn't gonna get integrated as well.
yeah, yeah,
For somebody like this, I can tell you I still work on the eyes and the vestibular system because it's set to the right.
yeah,
So part of the balance wonky stuff that they're doing is their vestibular system is holding them on the right side. So again, what got them there, what's keeping them there?
yeah,
It's easier on the right side. There's less pain on the right side. The vestibular system is set to the right side.
yeah, yeah.
All of those things are there.
No, we should do another episode on that because I'm doing something now for a course, and the vestibular ocular reflex. I know we've talked about it many times, but that is directly linked to your center of mass. Okay, especially when you're,
Absolutely.
I don't know
100%.
what you
It's
do.
the it's the reason that it's the reason that we are held on the earth the way that we are,
Yeah, yeah,
because the pull for our eyes to stay in alignment with the horizon is like it's hardwired into our system.
yeah, yeah,
It's hardwired into our system. And, it's an interesting thing, that happens unless you train that out of it. But it's hardwired into our system. It's going to keep us there.
yeah. Absolutely, I
And
agree.
that's why the upper cervical is so important. We have, like I said before, 50% of the proprioceptors in the body are located
Yeah,
in the suboccipital space. So tell me that the position of the head in space isn't important.
yeah,
It's it's
very,
it's just like I said, it's hardwired into our system.
yeah,
And the more we put ourselves in positions and ways to challenge and uh, rolling on and off of different things and doing different things, the better. Because
yeah,
we want to keep that system as nimble as possible. But sometimes we have to just teach it to shift first
yeah,
and get used to shifting a lot, doing a lot of different things, and then, really make it more nimble
yeah,
so that
yeah,
there's choices for it. The choice isn't the default to the right.
yeah, yeah. Exactly, exactly. Oh, this is a wonderful case, Susan. Anything else? Or are we? We good to go.
No, I think we're good to go. Looking forward to the comments below
Yeah,
and, and anybody, shoot us an email, let us know what you think.
yep.
And we look forward to seeing you all on the next one.
Yeah.
So anything you want to add?
No, just we're gonna do so we're still alternating, shorties every other week. So that these will also be on YouTube. We also have extended, we have an invitation for listeners to come on if you want
Right.
I mean, a mentoring session on a patient case. We've had a few listeners on already, and if you want to be a listener, I want to be a listener. If you want to come on, please email us at tough2treatpt@gmail.com. We would be thrilled to have you. And think of it this way. A lot of people, I've had a few people say, I get very nervous when I come on. I'm like, just think of it like a mentor call, like you're doing it. It's like a normal chit chat. We've been doing this a while now, so we're comfortable on Zoom. But don't be afraid. If you're afraid you're not going to come out right, that's not a reason to come on, not to come
Yeah.
on the
No,
podcast.
we're
Okay, it's
none of
not.
us none of us know what's going on. We all sit and just kind of have this conversation together to figure some things out and hopefully help you all with moving your clients forward too, because that's really kind of what it's all about, right?
Yep, yep. Advance our profession.
Yeah. All right. Thank
In
you,
the next
everybody.
episode. Bye.